spine. I wish to welcome all of you in behalf of FORTE. Maybe later on, if we have time, we can speak more about FORTE and the mission of FORTE and what is FORTE. So FORTE is the organization of young orthopedic surgeons, so of young specialists and residents in Europe. Today we will speak about two maybe topics that aren't so popular, so about basic science and spine, but we believe that we all lack a little bit of knowledge in those fields. So we can actually start. Can I please ask you to turn on the first presentation?
Is this with trauma principles?
Yes.
Okay.
Then do I have a so once again, the speakers. My name is Marko Ostojić. I'm current FORTE president. So, my name is Marko Ostojić. I'm the current FORTE president. This is the FORTE vice president, Vasilis Igoumenou from Germany, Tarek Bujakovic from Bosnia and Herzegovina, and Stefan Schwimbacher from Switzerland. So, I will try to cover in 20 minutes the trauma principles in let's say in AO perspective. So, what is trauma? Trauma is the commonest cause of death for age group of 1 to 44 years in the developed world. Road accidents are by far the commonest mechanism, and for every death, 3 victims suffer permanent disability. Of course, fast and effective emergency medical service is of paramount importance. About the diagnostics in trauma, these are some principles you probably all you know them very much so far, but we have the clinical signs and symptoms of the broken bone, which is a pathologic mobility, crepitations, and radiological studies. And of course, we have the deformity, pain, swelling, and loss of function. When we speak about the X-rays, you always have to do the 2 images. 2 images, usually AP and lateral-lateral. Of course, the 2 adjacent joints should be covered by an X-ray. Especially in pediatric orthopedics, you have to do the contralateral limb. You have to look for 2 injuries, and sometimes for some occult fractures, you have to do it in 2 occasions. So the importance of AP and lateral view is very well described here. You cannot see everything in one view. So, some basic science about bone myology and fracture mechanism. Bone is made of dense connective tissue. It is a living tissue. In the time of 10 years, all of our bone degrades and builds itself back again. So it's biologically active tissue. It has the minerals that give it the compressive strength and extracellular matrix, the organic part, that give it the tensile strength. So 70% actually bones are made of metal. So we have the parts of the bone, the epiphysis, metaphysis, diaphysis, and so on. Those are very much basics. The physical properties of bone. This is the stress-strain curve for the bone. The yield point is the part where the elastic deformity stops and the plastic deformity becomes active when the bone breaks. So, when does fracture occur? In the yield stress point, when the elasticity of bone cannot compensate the bending forces anymore. Of course, bone is fairly brittle in the old age when the bone breaks easier, so there is high probability of plastic deformation and failure. So remember the term plastic deformation. It's vice versa in children with the green stick fracture when the bones are extremely elastic. So, types of bone healing. It can be achieved by callus formation when there is micromotion present, and by direct union when the osteosynthesis is ideally stable. Callus, there are different phases of callus formation. We have the hematoma and inflammatory phase. the soft callus, hard callus, and consolidation and remodeling. Soft callus can already be seen on an X-ray as a scarcely calcified tissue. Callus forms in response to movement, not to splintage. So there has to be some micromotion present. There are certain fracture types. They result to injury, to repetitive stress, so we have stress fracture, and pathological weakening of the bone when we have a pathologic fracture. So a definition, a fracture is a break in structural continuity of the bone. So open fractures, when we speak about them, as residents, you will see many open fractures in the ER. So try to remember the Gustillo-Anderson. I'm looking myself on the video. Try to remember the Gustillo-Anderson classification. Fairly easy. Grade 1 is that the skin wound is less than 1 centimeter. Type 2, 1 to 10 centimeters. And then type 3 is when the skin wound is longer than 10 centimeters with different levels of soft tissue injury. When we are speaking about closed fracture, especially in the lower extremity, it still doesn't mean that the soft tissues aren't compromised. So we have the Cherner classification that also classifies the soft tissue damage on the bone trauma. When we speak about the fracture pattern, it actually depends a lot on the fracture pattern, how are we going to treat it, and it depends on our surgical technique. So if it's direct or indirect force, so bending causes transverse fracture, while torsional forces generally cause spiral fractures. There is a high energy and low energy fracture. Really important to take the history because it depends when are you going to time the surgery and which kind of osteosynthesis you're going to do there. So of course, if there is, let's say, high energy fracture of the lower leg in motorcycle accident, I wouldn't go for plating there. I would definitely put a nail if I can. Of course, if the fracture lets me put the nail. So these are the types. And of course, the way the bone dislocates. The bone can dislocate by translation, shift, so ad latus. It can angulate, it can rotate, and it can lose its length. Incomplete fractures, they are predominantly in children, with the green streak fracture as a most widely known example. Injury of the physis, this is the classification of Salter-Harris. It's very prognostic, so type 2 heals very well, type 3 and 4 so-so, type 5 usually brings some consequences. Stress fracture, it occurs in normal bone in response to repeated heavy loading. It's typical in athletes and military personnel, and heavy loading induces mini deformation, disproportion between bone resorption and new bone formation produces weak places in the bone. There are some bones that are prone to stress fractures, like fifth metatarsal, navicular bone, calcaneus, and tibial shaft. Fracture classifications, you pretty much learned many of them, and they usually bear the originator's name. They're useful for some part of the body, like Schatzker is for the proximal tibia. But AO classification is most widely used for general trauma. So the first number indicates bone, second number part of the bone, and third, actually a letter and number significate fracture pattern. So once you get used to that, you can actually know how does the fracture look like. Principles of osteosynthesis. There is, of course, conservative and operative treatment. But in all of them, we have to do the reposition of the fragments, retention, and afterwards the rehabilitation. So reduce, hold, exercise. The goal is prevention of displacement, not complete immobility. Once again, we have to have certain micromotion. Of course, when we speak about conservative therapy, we have different kinds of casts. They're usually made of plaster or fiberglass. Plaster of Paris or gypsum is most widely used. It's hard, no allergic reactions, no toxic ingredients, and of course it's cheap. And functional cast, you have probably seen the Sarmiento cast. And when you do the cast, watch for pressure source. Always use your palms, never your fingers, once you modulate it. Because when you use your fingers, you can create a pressure sore. After wearing the cast, of course, there is a stiffness for some time. When the swelling and hematoma subside, adhesion form. In extraarticular fractures, these adhesions are between the muscle fibers, which are attached to bone and to each other, so we have the muscle contracture. In intraarticular fracture, between the articular structures. Different kinds of splints that were used historically. It's less rigid than cast. Now it's adequate for ligament disruptions and later stages of bone fracture management, when the soft callus is already formed and when the fracture is, let's say, sticky. Continuous structures also used historically a lot. Lately, it's very scarcely indicated, except in children where we have the over-the-top or gallows traction. So if you have like a femoral fracture in a toddler, I would still treat him with a gallows traction. So, operative treatment. There are two key concepts that should be met: effective splinting of the fracture and controlled mobility of the joint. Of course, we have the external fixation, close reduction percutaneous pinning, plate and screws as part of the ORIF, and intramedullary nailing. X-fix was introduced by Lambot at the very beginning of 20th century. It's still widely used as part of early fracture management with soft tissue damage, management of polytrauma, and limb lengthening procedures. It enables the non-rigid osteosynthesis. Close reduction and percutaneous pinning. Now it's usually most in pediatric trauma, and in adults, in general rule, if the fracture is easy to reduce and nearly stable, and of course on small bones. Plate and screws as part of open reduction internal fixation. It's usually with interfragmentary leg screws. We can use the compression plate, the bridge plate, and AO philosophy in biological era is applied there. Intramedullary nailing, it's introduced by Gerhard Kincher in 1940s. It enables early articular motion and weight bearing. So usually people get on their feet fastest if we use intramedullary nailing. It preserves the vascularization and soft tissues. It can be rigid or flexible. Flexible is usually in pediatric trauma. Reamed or unreamed. It has proximal and distal locking, and it's ideal for diaphysis of long bones. Please remember, do not ask a nail what a nail cannot do. This fracture is too close to the knee. It's too close to the metaphysis for, in my opinion, for a nail to hold it. So, AO principles. AO was founded in 1950s in Switzerland. The fundamental principles didn't change for the last 60 years. Modifications known as the biological era have changed the point of view in the last 15, let's say, years. The formation of our AO school, these were the fathers of the AO. It was done in the 50s and 60s. Fundamentals of sound internal fixation. So, the restoration of anatomy, the first one. Stable fracture fixation. So these were the first rules of the AO. Preservation of blood supply and early mobilization of the limb and patient. Modifications of basic AO principles. Articular and diaphyseal fractures have different biological requirements. So, the type and timing of the surgical intervention must be guided by the degree of soft tissue envelope injury. Also dependent on patient physiological requirements. What does that mean in practice? Absolute stability is only important in articular fractures. In articular fractures, you cannot have any step off or gap. Ideally, the articular surface should be done with a step off of not more than 1 millimeter and with a gap of not more than 2 millimeters. Diaphyseal fracture can have a little bit of adlatus movement. It can be shortened a little bit, but it cannot be malrotated. So diaphyseal fracture does not have to be ideally anatomical, and only if it's obtained without damage to blood supply and massive soft tissue injury. So it has to be aligned. Look out for the rotation, but it doesn't have to be anatomically perfect like articular fracture. So the osteosynthesis stability, if there is minimal deformation, minimal micro movement, we have very, very slow healing. If there is a lot of deformation, we'll never have healing, but there is some micro motion that is needed, some strain for the callus formation. So, what is absolute stability? It has to be the mechanically neutral field has to be created. So we have to have the anatomical reposition and interfragmentary compression. They enable direct primary healing. It's a slow healing with minimal callus formation. It's ideal for articular and simple diaphyseal fractures. So we can put a leg screw that generates a lot of stress, but it's really rigid. It's good for some fractures. Usually a leg screw needs a neutralization plate. Leg screw can be also used with buttress plating, usually in proximal tibia, and that's a good example. Compressive plate. Original compressive plate was done with a compression device. Of course, now we use the DCP, dynamic compression plate, where we put the eccentrical screws and we get some compression there. Pearls. End hole has to be filled for torsional stability of the plate. Plate length matters more for bending stability than number of screws, and plate stress shields the area that covers. It protects the extremity, so you have to protect the extremity after removal of osteosynthetic device. Locked plate, it has become really popular in the last 15 years. It's a fixed angle construct, does not depend on bone plate friction. So you don't have to put it very much against the bone. You don't have to compress it against the bone. It has the locking screws, which provide the fixed angle support, and non-locking screws, which provide the bone compression. It's very good for periprosthetic fractures, for proximal humerus, for intra-articular distal femur, and proximal tibia. Okay, articular fracture example. So, restore the joint line. The joint line has to be, of course, ideally restored perfectly, and put the buttress plate for the fixed angle construct. There are some osteosynthetic materials that provide a relative stability, which can lead to callus formation. All of this enables secondary indirect healing, which is faster than the stable healing. K-wires, usually done in pediatric trauma, and when the expected healing is quick. Tangent band wiring, usually done for patella now. I like to do it for medial malleolus also. And bridge plate. Complex fracture can tolerate more interfragmentary movement than simple fracture can do. So, for the complex fracture, you put in a longer plate with a long distance between the screw. So you have more working length of the plant and stress distributes on the longer field of the plate. So, in a nutshell, when we do some kind of immobilization, compressive plates give us, with the leg screw, gives us this higher stability. Then if we go down, there is intramedullary nail, bridge plate, X-fix, and of course, cast. Surgical approach. When we speak, it can be open, minimal invasive, and percutaneous. Watch for patient positioning and surface anatomy. Surface anatomy. In med school, we don't learn much about surface anatomy. We learn many muscles, organs, tissues, structures, but we don't learn where it is under the skin. I mean, look at this pearl. If you put X fix on the second metacarpal, if you flex the finger, then the extensor tendon goes out of the way and you have the bone to put it much more safely. When we treat the open fractures, so all open fractures are generally contaminated. Infection is less than 2 degrees for G1, Gustilo-Anderson 1, and more than 10 degrees for Gustilo-Anderson 3. We have to use the antibiotics, debridement, bone stabilization, and cover the wound. So debridement to get a clear surgical field. Gentamicin is usually given immediately. Afterwards, we go with coamoxicillin, cefuroxime, and so on. We put in the X-fix. Now, if you have Gustilo-Anderson 1 with a skin wound of less than 1 centimeter, it's not contraindication to put in the plate and screws. So for the small one, open fracture, the literature shows there is no difference between intramedullary nailing and plate and screws. When doing the wound extension, especially on the lower leg, follow the usual entry lines for the compartment release, and for delivering bone ends to a visible field, do the exact position that fractured the bone, to not do any further damage. Of course, with delayed treatment, our goal is to convert it to intramedullary nail. Stress fractures, we already mentioned them. They are because of repeated heavy loading. Operative therapy of choice for the long bones is rimmed nail. Physial fractures, excellent prognosis for Southern Harris types 1 and 2, worse for 3 and 4, bad for 5. We can have the premature fusion and limb length discrepancy. We will really quickly go through the complications. So, compartment syndrome. Look for the 5 Ps. There is more and more talks about paresthesias. When you have paresthesias, that's pretty much the sign for a catastrophe that's coming. So paresthesia is pretty much the most sensitive symptom of these 5. So we all know what causes the compartment syndrome. It's the pressure in closed spaces in ossifascial compartments that exceeds capillary pressure. So muscle necrosis can actually happen in less than 6 hours, and Fortman's ischemic contracture can occur. When we speak about delayed union, there's no progression of healing over serial radiographs, usually 6 to 9 months. It can be caused by soft tissue damage, by imperfect reduction, or over-rigid fixation. There are some patient-related problems. But if you deperiosteed everything, removed the soft tissues, and did the over-rigid fixation, you have a chance of delayed union. There is a Perkins timetable that we can respect. Spiral fracture is up in upper limb. It unites in 3 weeks. Spiral fractures unite quicker than the transverse fracture. For consolidation, do ×2. For the lower limb, because it's a weight-bearing limb, go ×2 again. And for transverse fractures, go ×2 again, to be on the safe side. Non-union, the situation where fracture will never unite without an intervention, I would say after 9 months. There is hypertrophic and entrophic. We have to provide the contact, the alignment, the stability, and biological stimulation. We need to identify the possible infection, correct the deformity, and provide the stability. Autologous bone grafting is a viable choice, BMP, demineralized bone matrix, and so on. Malunion, if we have the angulation on malrotation, shortening shouldn't be more than 1.5 centimeters in adult lower extremity, and angulation, if it's more than 10 to 15 degrees, it leads to asymmetric loading of the weight-bearing joints. Avascular necrosis, some parts of the body are prone to it, like femoral head, scaphoid, lunate, and talus body. Osteoporosis of the fragment is a good sign. It means revascularization. That's Hawkins' sign on the dome of the talus. Myositis ossificans common in hip, elbow, and shoulder fracture. If you think there is a chance for myocytic ossificans do the prophylaxis by indomethacin. One more slide about child abuse. Try to look for the pathological family, not the pathological fracture. Try to find signs of better child. Better means when people do like this to a kid. So usually by drug addicts, most common fractures are spiral humerus fracture of distal physical separation, spiral femur fracture in toddler, and posterior rib fractures. Missed abuse leads to 33% of further abuse and 10% of child death in the future. Thank you very much.
Thank you very much. I think in 20 minutes you cannot tell everything about fractures, so it's normal. So now Dr. Bujakovic from Bosnia and Herzegovina will tell us, we'll keep on moving today with the next talk. You're going to do both talks, muscle and tendons, and then they repair everything, huh?
Yeah.
Yes.
Yeah. Well, hi, hello for everybody. My name is Stari Bujakovic and I'm a fourth-year resident from Bosnia and Herzegovina, Tuzla. I will talk about the muscle, tendon, ligaments, and the nerve healing and repair. As much as I prepare this presentation, I realize how little I know about this theme, and like Marco said, it's not popular. But let's start. Mesodermal origin, mononucleated myoblasts form to fuse the myocytes. Matter cells, myocytes, or muscle fibers are built by the sarcoplasm and the sarcolemma, and they contain for about 80% of the contractile protein. On this picture here, we can see the myofibers, which build the bundles, and the bundles are fused to form the fascicles and the muscle. We see also here the T-tubules, which connect the cercoplasmatic reticulum, which contain the calcium, which is important for the muscle contraction. Muscles are surrounded by the shield. For example, endomysium surround the fibers, perimysium surround the fascicles, and epimysium surround the muscles. The main functional units of the muscles are the sarcomere, the main contractile proteins which made the myofibers are actin and the myosin. Well, in the sarcomere, it's built by the I-band. I-band contains the Z-line, which is the terminus of the sarcomere and connect the sarcomere with each other. The A-band contains H-zone, which is the center of the sarcomere, and the M-line, which connect the myosin with each other. Actin is the globular protein, tropomyosin, is built by the tropomyosin and the troponin. Troponin has the place for the binding of the calcium, and tropomyosin block connection between the actin and myosin. Myosin is built by the 6 subunits, has the 2 heavy chains, S1 and S2 subunit. S1 subunit is the head, which connect to the actin, and S2 is the flexible neck. Depolarization release the acetylcholine in the neuromuscular junction. Acetylcholine connect to the acetylcholine's receptor and induce releasing of the calcium from the cercoplasmatic reticulum. Calcium bind to the troponin and induce changing in the structure of the tropomyosin and allow a connection between actin and myosin, and then we have a muscle contraction. Myotendinous junction is the weak link and most often site of the tears, especially in eccentric contractions. When we are talking about type of the muscles, according to the amplitude of contraction, we can talk about isotonic, isometric, and isokinetic contraction. Isotonic contraction is a measure of the dynamic strength. Isometric contraction is the measure of the static strength, and isokinetic contraction is the contraction of the muscles, where the muscles are under the maximal tension through over a full range of motion under constant velocity. Muscle fibers are divided into type 1 and type 2 fibers. Type 1 fibers are red fibers, contain a lot of mitochondrial, and enable us to perform endurance activity and first lost if we miss rehabilitations. Types 2 fibers are white fibers, has larger and stronger motor units and enable us to perform high intensity and short duration activities, for example, sprinting. Strains, most common sport injury, most occur at the myotendinous junctions. They occur primarily in the muscles crossing two joints. And initially we have inflammation, and after a while there is fibrosis. Tears also occur at the myotendinous junction, usually during rapid eccentric contraction. If we do a surgical repair, we have a minimal regeneration of the muscles, recovery of about only half of the muscle strength, and scar formation. If we put immobilization, it lowers the number of the sarcomere and accelerates granulation tissue response. Immobilization in lengthened position decreases the contractures and the atrophy of the muscles as a result of disuse. Can afford these effects by electrical stimulations. Ligaments and tendons. Ligaments connect bone to bone, provide stability and proprioception. Tendon connect muscle to bone and transmit tensile force, optimize lever arm, or store energy. Are built by the cells and extracellular matrix. And the extracellular matrix are collagen, proteoglycans, and elastin. Collagen is predominantly collagen type 1 in about 90%, collagen type 3 10%, and small amounts of collagen type 4. Proteoglycans connect the collagen with each other and aggregate in the contact with water and provide stability. There is also glycoproteins and plasma proteins. Elastin is synthesized by fibroblasts, has large capacity for stretching and important for recovery after loading, but has only 1/5 strength of the collagen fibers. In the insertion of tendons and ligaments, there are four zones. Well, we can explain it right here. The first zone is the collagen fibers, which are parallel to each other. When they cross the fibroblast, fibrocartilage tissue, there is zone 2. Zone 4 is the mineral zone. It's mineralization of the fibrocartilage, and the mineralized fibrocartilage across the bone, there is zone 4. Between zone 2 and zone 3 is the most common place for injuries. Knee and ankle ligaments are most commonly injured. Ligaments do not plastically deform, so they break, don't bend. Mid-substance injury are common in adults. Avulsion are common in children. Well, healing go to the 4 phases. The 4 phases in the first 48 hours. There is inflammation phase. We have releasing of the pro-inflammatory factors, growth factor, and we have the synthesis of collagen type 3 in the inflammatory phase. The next phase is proliferative phase. There is conversion of the collagen type 3 into the collagen type 1, which is much stronger structure. And then we have remodeling and consolidation, which can take for about 12 months, like we see here. Nervous system is divided in the central, peripheral, and autonomic nerve system. Central contain brain and the spinal cord. Peripheral nerve system, cranial, spinal, and the peripheral nerves, and the autonomic nerve system, like we know, sympathetic and parasympathetic. Nerves are built by the neurons. Neuron contain the cell body, short terminus called dendrite and long terminus called axon. Axon is surrounded by the glia cells. So glia cells provide support and insulation the nerve system. In the central nerve system we have oligodendrocytes, astrocytes, and microglia cells. Oligodendrocytes provide myelin sheath over the axon. Schwann cells provide the myelin shelved into the peripheral nervous system. Gaps between the Schwann cells are Ranvier nodes and provide the saltatory conduction of the impulse, which is much faster. Well, nerves are surrounded by endoneurium, perineurium, and epineurium. Endoneurium surrounds the neural fibers, perineurium fascicles, and epineurium whole nerves. It's important to understand because we have to understand the injury of the nerves. Action potential, resting membrane potential is minus 70. It's maintained by the lipid membrane, selective permeability of the ion channel, and NAK exchange pump. The threshold stimulates the opening of the sodium channel, so any influx into the cells, so we have depolarization. It increases the membrane potential to the plus 10. In depolarization, it takes only 1 millisecond, and after that, it's repolarization. So I talked about the injury of the nerve. According to Sunderland classification, there are 5 types of the nerve injury. The basic nerve injury is the neuropraxia. Neuropraxia is determined when we are talking about the nerves. The nerve tissue is not damaged, but we have only the problems with conduction of the impulse to the nerves. And we can expect regeneration. Grade 2 is axonotmesis. In axonotmesis, we have damage in the neural fibers, but the surrounding shell, which we talked about before, is not injured. So we can expect the regeneration. And type 3, 4, and 5 are the types where we have injury of the shells, and we need the surgical treatment. Axon grows for 1 millimeter per day, and possibly in 3 to 5 millimeters in children. We have neurotropic activity where the growth factor, for example, released and enhance the growth. Pain is the first sensation to return. Prognosis is determined by energy, age, gap between the ends, and for all. Nerves are sensitive for stretching. 8% elongation, diminished circulation, but 15% we can expect axonotmesis or neurotmesis. Nerve repair, for a repair of the nerve, proper alignment is crucial, and younger patient has better chance of recovery. Thank you. We can proceed for the next presentation. Yeah, metabolic bone. Metabolic bone disease and inflammatory arthropathies. Well, the vitamin D is important factor in the metabolism of the bones, so we intake it by the food or exposing to sunlight. We intake the ergocalciferol and cholecalciferol. They in the liver under the 25-hydroxylase convert to the 25-hydroxycholecalciferol, and in the kidneys under the alpha hydroxylase into the active form 1.25-dehydroxycholecalciferol, which is the active form. It induces increased reabsorption of the calcium in the intestine, increased reabsorption of the calcium in the renal tubule, and increased activity of the osteoblasts in the bones. Calcium is essential for blood coagulations, nerve conduction, and the muscle contractions. Increase in the calcium in the plasma we call the hypercalcemia, excessive rise, and can lead to depressed neuromuscular transmission, or decrease the calcium in the serum we call hypocalcemia, and is connected with the tetany. Normal concentration is between 2.2 and 2.6. Absorption can be inhibited by the phosphates, oxalates, phytates, fats, corticosteroid, or some inflammatory bowel disease. Parathyroid hormone is an important factor in the regulation of the metabolism of the calcium. So parathyroid hormone increases renal tubular reabsorption, enhance intestinal reabsorption, and also increase activity of the osteoclast. So osteoclast resorb the calcium from the bone and increase the level of the calcium in the serum. Some malignant disease could imitate some factor who increase the level of the calcium. For example, squamous cell cancer induce production of the parathyroid hormone-related peptide. Hodgkin lymphoma is connected with increased production of the cholesterol, and men type 1 and type 2 syndrome are connected with parathyroid hormone increased production, or type 2 is connected with medullary thyroid carcinoma. Osteoporosis is a clinical disorder. It is characterized by an abnormally low bone mass and defect in the bone structures. Combination which render the bone unusually fragile and at greater than normal risk of fracture in person of that age, sex, and race. The risk factor for osteoporosis are age, female, previous fragility, fracture, low body mass index, smoking, alcohol abuse. Here we can see the diagram which show us increased level of the fracture of the vertebral hip and the wrist in the postmenopausal female. Women's. Osteoporosis cannot be diagnosed by the plain X-ray, but we can measure the decression of the vertebral body. If we have moderate or severe decression, which is higher than 25%, we can predict sooner hip fracture, for example. DXA is the gold standard for diagnosis of the osteoporosis. Treatment current goal is to reduce future fracture, and medication we use for 3 to 5 years and have to repeat the XA. Inadequate mineralization of the bone in children is rickets, and in adult is osteomalacia. The crucial problem is reduced serum active form of the vitamin D. To different osteomyelitis between the osteoporosis, we only can with the XA. We have to measure the T-score. If the T-score is between -1 and -2.5, it is osteomalacia. If it is lower than -2.5, it is osteoporosis. In the children, we have a special clinical feature, for example, bovine legs, rickets rosary, craniotabes, or Harrison sulcus. On the X-ray, we have widening of the epiphysis and flaring of the metaphysis because of protruding of both acetabulum. We have the champagne glass pelvis. Also osteoporosis, we can see by the biconcave form of the vertebral bodies and loser's zone in the pelvis. Chronic kidney disease is also connected with mineral bone disorder. Well, here, because of the acidosis and the increased level of the sclerostin, we have the osteoblast function impaired. Also, we have increased bone turnover because of increased activity of FGF23. And because of the low level of the calcium, we have secondary hyperparathyroidism. Well, the X-ray signs, here is the Jersey rocket sign. It is the hypersclerosis of the end plate of the vertebral bodies. Also, we have hypercalcification, like we see here on the vascular structure. We have increased fracture risk, growth retardation, slip epiphysis, and vascular calcification. Hyperparathyroidism can be primary, secondary, or tertiary. Primary is induced by the adenoma of the glandular tissue. Secondary is because of prolonged hypocalcemia, and tertiary is because of the hyperactivity of the glandular tissue. The calcium bind to the calcium sensing receptor and induce the cascade which product the parathyroid hormone. Parathyroid hormone acts to the bone to increase activity of osteoclasts. In the kidneys, activate reabsorption calcium from the tubule and also increase resorption calcium from the bowels. Special clinical feature on the radiological signs are osteoporosis, erosion on the long bones, for example here on the proximal humerus, pathognomonic erosions in the middle phalanx of the hand, and we have also brown tumor with pathologic fracture. Paget bone disease has increased level of the FGF23. FGF23 increased level of the bone turnovers. So it increases activity of the osteoclast and osteoblast too. Because of increased activity of osteoblast, we have a widening of the bones, but osteoclast damage the architecture of the bone, and the bone becomes weak. So because of the weakening of the bone, we have the special deformities. Bones looks like they have been eaten by the moth. Inflammatory arthropathies. Well, I would say some sentence about the cartilage tissue. The cartilage tissue is built by the 4 zones. The superficial zone is the zone which contain a lot of collagen and proteoglycans. Collagen fibers are parallel to the surface. Middle zone is the next zone. It has a randomize of the collagen fibers and the fibroblasts, and has a higher percent of the water. Deep zone has perpendicular fibers to the subchondral bone and has lower percent of the water and proteoglycans. And the calcified zone is a zone just next to the subchondral bone and has a lowest percent of the water, for example. T lymphocytes are the most important factors in a cascade of activity in the inflammatory bone disease. For example, they produce tumor necrosis factor, interleukin 1, 6, and 17, and activate production of the neutrophil and macrophage. Also activate synovial fibroblast, which induce production of the lysine and induce the chondrolysis. Neutrophils induce matrix degradation, and macrophage also, except matrix degradation, they activate the epithelial vascular tissue and form the spans. Interleukin 1, by the converting plasminogen from the plasminogen to plasmin, induce the matrix protein degradations. Also, collagen activation of the collagenase induce the degradation of the collagen fibers, and stromalysine induce degradation of the proteoglycans. Tumor necrosis factor induce panus, like I said, by inducing hyperactivity of the vascular tissue. Also increase activity of the osteoclasts, osteoclastogenesis, and decrease activity of osteoblasts. So increase reabsorption of the calcium and special erosion on the bones, which we can see on in the patient's radiological signs. Joint trauma or overuse induce a cascade of reaction in the bone tissue and joints, which can lead to the special signs like erosion of the bones, erosion of the cartilage tissue, and degradation of the cartilage. So, thank you.
Thank you very much. Well, I don't know if I'm very nice with that thing.
Now, Vice President of the FORTE, Dr. Vasily Sigumenov from Germany.
Hi guys. So, I'm not feeling much comfortable with, since I quit stand-up comedy. I don't know. It's now. Okay. Maybe I will do it from here. Huh? Yeah, here's better. Yeah, nice. Mic off. Yeah. So, yeah, I know you guys, you're not very much into basic science and why it's not working. Yeah, of course. So actually, orthopedic infections. This is a lecture that can be for a whole day. We can talk about it and make a whole congress about orthopedic infections. And I decided actually not to stick on the theme like antibiotics, germs, bacteria, and so on. And we will talk about. I have no conflict of interest. And we will talk actually about osteomyelitis, FRIs, and PJIs. I skipped spondylodiscitis because if I start speaking about spondylodiscitis, then I will not end it. So let's talk about some more, at least interesting things about orthopedic infections. And we will start with osteomyelitis. Osteomyelitis is an infection of the bone. I'm pretty sure that you're very familiar with these risk factors. Actually, in few words, AIDS, obesity, drugs, alcohol, cigarette smoking, and other conditions that may lead to an immunosufficiency may lead to osteomyelitis. This clinic in Germany, it's not my clinic, but it's a clinic that they're very specialized center in the whole country. They're specialized and they show us actually what are steps in the treatment of an infection should be. And this is first of all treatment of the infection, then the soft tissue defects, the bone defects, and then at the end the patient should be rehabilitated. So we have to treat the infection. What do we do? First of all, we have to have some cultures from the bacteria that we have. That's why we have to clean, we have to go there, we have to perform a surgery, we have to remove every necrotic tissues, and we have to take some samples, okay? But every necrotic tissue has to be removed. When we remove the necrotic tissues, then we have, then we have to treat the soft tissue defects, okay? And when we have, actually, we remove, on this first step, when we remove the soft tissues, then we have to bridge also the gap. We have to perform maybe an X-fix to stabilize our bone defects. Our bone to have instability there. So we perform maybe an X-fix. And when we have a very healthy envelope, because the envelope of the bone is very important, then we can go on and treat the soft tissue defects. And then, when we really have a good envelope, we can start going with the bone defects. And with the bone defects, we have a variety of measures. We have the external fixator, the Ilizarov device, the development of the Ilizarov device is a Taylor frame. And with the Taylor frame, we can perform the limb shortening, and then the distraction, which will lead us to the real lengthening of the limb. We have also the Masquelet technique. The Masquelet technique is it's not such an easy technique to perform. Actually, you can only remember the induced membrane bone growth, okay? What do we do there? We try to give the body the message that it has to grow some bone there. This is done with multiple operations, multiple procedures, and it can last a few months. And then if we have such a large defect where we cannot restore it with other ways, there's also the solution. This is actually a nail with cement in order to keep the space and treat the infection locally. And when we have healthy tissues, we can perform also a total limb replacement with these oncological devices. You have also to remember that at the end of osteomyelitis, we have to rehabilitate the patient, okay? Now, some more interesting stuff about you, the fracture-related infections. The fracture-related infections are infections that take place after a fracture, after fracture management. Of course, if you see any signs of fistula, sinus, wound breakdown, or if you have two positive cultures of intraoperative specimens, then you have the confirmatory criteria that you have an infection. All other criteria, ECR, white blood cell count, CRP, and clinical signs are suggestive criteria. So the Czerny classification, not the Czerny, as Marco said, the Czerny classification is a classification, it's a pretty simple classification. This guy here in the mid-80s told us actually that we actually have 4 types of osteomyelitis. This is the medullary, the superficial, the localized, which is both superficial and medullary, and the diffuse. What Czerny introduced actually, it was important, it is the physiological host. This means that we have also to look our patient. If we have a host C patient, this means that we have a very morbid patient, and maybe there we can consider that the not only the cost, but also the burden for the patient to be treated multiply does not make any sense. And then we have to think about amputating or suppressing the infection. I think you all know about this: early, delayed, late infection. And then this is a more recent classification. To be honest, I don't know if this has any practical use. I think it could be more complicated like that. But okay, the future will tell us. You have to remember that an FRI is not a PJI. Why? We have instability. And this is very important, and keep this word in mind, instability. Because instability is very, very closely related to infection. Sometimes we have also to consider that a complete eradication of the infection may not always be the initial goal. What does AO tell us? AO tells us that a fracture is considered a soft tissue injury plus bone discontinuity. That means it's a complicated injury, and that FRIs are much more common than PJIs. Also, what they tell us is that we have to remove any necrotic tissue, but not that much aggressive to remove vital tissues, because vital tissues are the means of transplantation for the antibiotics to reach our bone. So we don't have to remove everything. And when we go to surgery, what do? The very well-known Day0, and the two components, debridement and antibiotics, are common for both therapies. And either we do implant retention, or implant removal, or implant exchange. I will tell you what we're doing now. I'm sorry. It's very important we have to see our stability of the implant, the stability of the fracture, our host, what kind of patients we have, and if our reduction is acceptable. I did this small algorithm here. So we debride, we do a wound lavage. The debridement can give us the microbiology specimens, which have to be at least 5, and this may lead us to a targeted treatment. Then with the wound lavage, after the wound lavage, we have to do something about the dead space, okay? We don't have to leave any dead space there. So we cover, maybe we can fill this with cement or with a negative pressure device, with a vac device. And then when we have some healthy tissues, we can do the soft tissue management and the bone fragment stability. Then comes this here in place, the retention, removal, or exchange of implants. And this will lead us to a definite reconstruction or to the suppression of the infection. I won't talk about everything here. Just look at the last 3 points. We have to debride after day 1 or 2 days again. You have to go there a second time. And it's it's of utmost importance, the wound closure with any kind of either cement or a vac pump. Our antibiotics is very important. Do not administer the patient antibiotics prior to your diagnosis. Only to patients with sepsis is this acceptable. To other patients, do the surgery, take your cultures, and then you can administer the antibiotics. First of empiric antibiotics, according to your suggestion, and then accordingly adjust. For how long? There's a big dispute, there's a bit arguing in the literature. I would say be safe and do it for 6 weeks in total, 6 to 12 weeks. This is what I was telling you. We have to preserve a very soft balance between instability and infection. If we have instability, we will not have a treatment of the infection, and on the other way, if we have an infection, then you have a pseudoarthrosis. Okay, so we have implants that they are infected, and on the same time, these implants are very important for the stability. And how do we keep this balance? We have ORIFs, nailing, and serofixation. This is the most easy infection to treat. It's a pin track infection mostly. About ORIF and intramedullary nailing, in ORIF we have the bone fragment devascularization. When we see that our implant is stable, then we can retain the implant, and then we do a suppression therapy, and when we see that the fracture is healed, we can do the eradication of the infection. Otherwise, if our implant is unstable, we remove it, we do an X-fix, and then we do the eradication of the infection immediately, and in the future we may think about ways of restoring any bone deformity or something like that. Okay, so stable implant, yes. Retain, no. We remove and do an X fix. If we have a nail here, the situation is complicated, yes and no. We have to remove it. If we have this device in our armoire, it's a Riemer irrigator aspirator device. This would be very useful. If not, we may remove it, wash it good, do some irrigation there, and we can insert there a new nail. This is the RIA, the Riemer irrigator aspirator. Some cement beads are also proposed as a bridging solution, not for stability. We have to have stability here to do these cement beads. And these are nails with antibiotics, loaded with antibiotics and cement. And the external fixation, as I said, you never remove the external fixator, we just replace the pins. The defect, again, the same strategy with osteomyelitis, either a Taylor frame or a muscular technique or a free vascularized Stroud graft. And you can have also cancellous bone graft, but it's pretty much the same techniques here. And do not forget, rehabilitation and follow-up is of utmost importance also. And now about the hot topic, PJIs. The more we have, the more we do knees and hips, the more infections we have. Okay, the last years we have more and more in hips and knees, and that's why we have also an increased number of infections, and that will be more and more increasing because the population is getting older, and the older patients are more and more healthier. And if you're 80 nowadays, you want to still play golf or do tennis, and they come and complain about these things. I don't want to say many things about the risk factors. I believe you know many of them. Keep in mind, I'm not such a fan of operating quickly, like keeping track of time, but in orthoplasty is very important, in spine surgery also, to do it in a shorter time, because that's how you may avoid infections. There are many ways to avoid infections. You're a perfect surgeon, you've done everything good. The patient has a very nice diabetes control. You did an antiseptic body wash with antiseptic, preoperative antibiotics. During your surgery, nobody entered the room, the theater. You had a very nice and clean environment. You monitored everything, but the patient developed an infection. Here, if you have an infection in less than 4 weeks, we have an acute infection, subacute infection, intermediate within 4 and 10 weeks, and after and in the longer period of time, after 2 years, you have a late infection. Here we have some differences in the pathogens. Staph aureus is very aggressive and most probably will cause an acute infection, whereas Streptococcus, Staph aureus also may lead to late, but not that common, and gram-negative bacteria will lead to a more delayed, more late infection. Again, all these values are important, but we don't have to stick on them because will not be that predictive. You have, though, to stick on microscopic culture and histology. Okay, you have to take samples and you have to send all these samples for microscopy, histology, and cultures. Why? Because of all these reasons. Okay, it's important to send all of them, and how many? About 3 to 6. This is the golden number, not less, not more. It's not going to be, you're just going to spend money. Do not do swabs, okay? Only tissues. And again, please do not give antibiotics before you take your samples. If you have one sample positive, then you can regard it as a diagnostic criterion, because only in these cases, if you have Staph aureus, if you have something pyogenous, if you have a fistule, if the culture is gram positive, and if the laboratory calls you and says to you, "Hey man, we have positive results." After 10 hours, we have already some positive cultures. Then we know that it's a very aggressive pathogen, and we have to treat it. We have also this weapon in our armoire, sonication. I know it's not available everywhere, but all these fine studies have shown that sonication is doing great work. And if you have it, if you have the luck to have it in your hospital, it will be very good. Because actually, we have here in this period of time. If someone does the mistake to administer antibiotics to the patient, sonication seems to have a very good sensitivity up to 14 days. So if I give the patient today antibiotics and I do the surgery in 1 week, if I have sonication, the sensitivity of sonication is very good. And this man here, Dr. Parvizi, is the Professor Parvizi. If you search the literature, you'll come across his name everywhere about PJIs. And the periprosthetic joint infections group have given us these criteria to diagnose the PJI. Actually, if you have one of these two criterion, either positive cultures, two positive cultures, or a sinus tract above your joint, you can say with certainty that you have a PJI. The rest of the criteria, I don't want to say many words about this here, but you can search it everywhere in the literature. You just have to have a score. Each of these criteria by itself does not say definitely that we have an infection. It is a combination of criteria, okay? And most importantly, you have to take synovial fluid, okay, where we see the white blood cell count, the alpha defensin, and the polymorphopurines, and the CRP. Now, we see that if we have an acute PJI, comparing it with a chronic PJI, we see that the differences in the pathogens are that pathogens with high virulence, like Staph aureus and Escherichia coli or Pseudomonas, may lead to this situation, whereas coagulants negative, like Staph epidermis, epidermidis, Staph capitis, and Cutibacterium may lead to a chronic. This plays a role for our biofilm, the well-known, the very known biofilm. Why do we care about biofilm? Because it is of utmost importance. We have a PJI, we do our surgery. What do? If it's an acute PJI, again, we have to do with biofilm here. We consider the PJI as not having a biofilm. That means that we can remove the chains, the mobile parts, and we can retain the fixed components. This is in 4 weeks, okay? We give 2 weeks antibiotics through the vein, and then oral antibiotics. If we do an one-stage exchange, and there is a big controversy between actually the German-speaking countries and the States and the UK about one-stage or two-stage exchange. Actually, they say that there is no big difference. This is actually to surgeon preference. If you do one-stage exchange, again, 2 weeks antibiotics, and then 10 weeks oral antibiotics. If you do a two-stage exchange, then you do actually 3 weeks intravenous antibiotics, and either you do it here where you re-implant the exchange, the removed implantation, or if you wait for 4 weeks until you do the reimplantation, then after you do the reimplantation, you give also the patient 1 week intravenous antibiotics, and then the rest through oral antibiotics. The soft tissue coverage here may be a problem, not that often as by FRIs or osteomyelitis, but consult maybe a plastic surgeon if you're not so familiar with ways to cover your wound. In rare cases, you may end up, and I think some of us have witnessed here, people being amputated after an infected PJI. This is a very sad situation, but it may be the only solution, either arthrodesis, amputation, or suppression. That means that the patient may need antibiotics for the rest of his life. Now, I will end with this, maybe boring or not boring. Actually, when we have Staph aureus, if it's an MSSA, we will do, my time is up, we will give cefazolin or flucloxacillin. If you have MRSA, vancomycin, and then a good alternative for the oral therapy is linezolid. I would always suggest the addition of rifampicin if the patient can hold it, because it's very good for the biofilm retention. For the other pathogens, I would go with penicillin G where it can be applied. Otherwise, the other here alternatives, but this is something that also with consultancy with your you will find, with laboratory, you will find a solution. And at last, this is a paper that you may read, you may search. I found it very interesting. The 20 common errors in the diagnosis of PJIs. And here, the authors highlight the most common errors that we do in this treatment. And as you see, the most common errors are delayed diagnosis, swab samples, synovial fluid diagnosis incomplete, inadequate number of tissue samples, and error that can be managed, can be well treated. And in your treatment, as I said, treatment with antibiotics very early, prior to microbiological diagnosis, arthroscopic lavage is also, some surgeons also do that. They just want to do an arthroscopy and wash out a hip infection. And the antibiotic holiday. Never stop antibiotics, okay? But you can search it more. It's an interesting and very didactic paper. Thank you very much for your attention. And
so, Dr. Stefan Schwimbacher from Switzerland will present us about the bioimplants.
So thank you for the introduction. Thank you, Marco, for inviting me to the meeting. I will do this presentation that covers the basic aspects of biomaterials relevant to clinical practice, including their mechanical properties and uses for implants, and it outlines the clinically relevant aspects, principles, and facts that are relevant to many surgical decisions. So I have nothing to disclose. So the surgeon's understanding of orthopedic implant technology is enhanced by a basic knowledge of mechanics. Once one has an understanding of how mechanical properties of materials are determined, one has a better appreciation of why certain materials in orthopedics are utilized rather than others. Orthopedic implants are depending on material and structural properties. Biomaterials encompasses all synthetic and natural materials used during orthopedic procedures. There are some basic definitions you should know about. There is the load, there's the force that acts on a body, the stress, that is the intensity of an internal force calculated by a force to the area, and there's the strain, that is the relative measure of the deformation of an object calculated by change in length towards the original length. So the first concept to emphasize is the stress-strain diagram, a useful graphical tool for illustrating the static behavior of systems that are elastic, viscoelastic, and plastic. Stress is defined as the applied force per unit cross-sectional area of the test piece. So, and the strain is defined as the increase in strength, increase in length as a fraction of the original length. So let's have a look at the diagram and the various terms I displayed. There's the elastic zone. It's the zone where a material will return to its original shape for a given amount of stress. Then there is the yield point. It's the transition point between elastic and plastic deformation. There is the plastic zone. It's the zone where a material will not return to its original shape for a given amount of stress. And there is the breaking point where the object fails and breaks at the end. The ultimate strength is defined as the load to failure, and then we have the two laws important to understand, the Hooke's law and the Young's modulus of elasticity. The Hooke's law is when a material is loaded in the elastic zone, the stress is proportional to the strain. And the Young's modulus of elasticity measures the stiffness of a material in the elastic zone, calculated by measuring the slope of the stress-strain curve in the elastic zone. So a higher modulus of elasticity indicates a stiffer material. So several features of the doesn't go ahead. No. So there are several features of the stress-strain diagram in the figure are important and define the mechanical properties of the material or device being tested. As you go down the material, it becomes more and more, it becomes less stiff the more down you go. So with an understanding of how mechanical properties of materials are determined, one has a better appreciation of why certain materials in orthopedics are utilized over others. Comparing these properties here on the table to bone allows a better comparison of the material's properties and use in orthopedics. So the more similar a material's mechanical property are to bone, the less stress shielding is created. So for example, if the properties of a femoral component in a total hip replacement are more similar to bone, there will be less stress shielding of the proximal femoral bone and the lowest stress riser at the tip of the femoral stem, thereby decreasing the risk of periprosthetic fracture. This is just one of multiple examples of how a better understanding of biomechanics and material properties enhances a surgeon's ability to make an educated decision concerning the products utilized in the treatment of his patients. So which kind of implants are frequently used in orthopedic surgery? We have, first of all, the screws, the plates, the intramedullary nails, external fixators, and hip, knee, shoulder implants, most of all. So we have different type of screws. There can be a cortical screw, canceller screw, or locking screw. So a plate is generally a load-bearing device that is most effective when placed on the tension side. The blade working distance is between the length of the two screws closest to the fracture on each end of the fracture. Decreasing the working distance, decreasing this distance increases the stiffness on the fixation construction, and the structural properties of the plates are the bending rigidity proportional to thickness to the third power, and the titanium has the Young's modulus of elasticity that most closely approximates cortical bone. So then from the biomechanical point of view, we heard already, the plate can be used as absolute or relative stability. The absolute stability constructs heel with primary healing, must eliminate micromotion with leg screw fixation, and must be low strain at fracture site with a high fixation stiffness. While the relative stability constructs heel with secondary healing, but the strain rates must be less than 10% or fibrous union will predominate. So there are some plate variations or functions that can be used in a different variation, like concave plates, locking plates, or bridging plates. Like placing a concave plate on a bending on a plate is useful in transverse fractures, for example, like here, to ensure compressive forces on both the far and near cortices of the fracture. Compression plates work by placing a cortical screw eccentrical into an oval hole in the plate, like we see here, and to place the cortical screw eccentrically away from the fracture in order to achieve this compression to the fracture site. So the locking plate does not have to precisely contact the underlying bone in all areas. When screws are tightened, they lock to the threaded screw holes of the plate, stabilizing the segments without pulling the bone to the plate. So the advantages of locking plates are that it can be used to indirect fracture reduction in diaphyseal metaphyseal fractures in osteoporotic bone. It can be used for bridging of several comminuted fractures, and it can be also used as a percutaneous locking plates possibly. It utilizes locking and non-locking screw in order to assist with fracture reduction, as well as provide a fixed angle construct with locking screws. So furthermore, the locking plate provides a relative stability, relative length, and alignment. It preserves the blood supply to the fracture fragments as the fracture site is undisturbed during the operative procedure. This theoretically improves the secondary bone healing. It allows some motion at fracture site, and relative stability leads to a callus formation. So the intramedullary nail, also we already heard, is a load sharing device where the radius of the nail is greater than the radius of the curvature of the femur. And there are some interlocking options like the dynamic locking for axially and rotationally stable fracture, static locking, and there is the option to do a secondary dynamization for a non-union. So about the implants, I put out the hip and the shoulder implants. Regarding the hip implants, there are some aspects to be familiar with. The rigidity depends on the length and radius of the femoral stem. So placing the femoral component in neutral or slight valgus reduces the moment arm and stress on the cement. Increasing femoral offset thus increase the lever arm to the abductor muscles and decreases the joint traction forces, reduces the abductor force required for normal gait, but the disadvantages are that it increases the strain on implant and increases the strain on the medial cement mantle. So I put out the reverse shoulder arthroplasty, which is a type of shoulder arthroplasty that uses a convex glenoid hemispheric ball and a concave humerus articulating cup to reconstruct the glenohumeral joint. So, and this is where the center of rotation is moved inferiorly and medially, which allows the deltoid muscle to act on a longer fulcrum and have more mechanical advantage. This does not significantly help the shoulder internal or external rotation, but if it can be combined with a latissimus dorsi transfer to assist with external rotation. Yes, thank you.
Thank you, Stefan Schwimba. Huh?
I do the next also? No. Okay. Okay.
So now Marco will do the lecture for tribology. As we have time, actually, if you have any questions about the presentations, if we have time at the end, we can discuss about this. And let's go through the tribology. Yeah.
So I declare no conflicts of interest about this topic. So, what are the learning objectives in biotribology? We won't do the whole presentation, we will just do the tribology part, to define basic tribology terms, to go more into details about combination of tribology and corrosion, and to resolve clinical examples and apply basic science into clinical settings. What is tribology? The study of the interaction of two solid surfaces in relative motion. It's a branch of science and technology that deals with the principles of friction, wear, and lubrication. The British physicists Peter Jost and David Tabor coined the term, and of course Sir John Charlie applied it into a clinical practice with low friction hip arthroplasty. This is the famous photo of Martin Algever on the first AO course ever teaching John Charlie. So, friction is a force that resists movement between two surfaces in contact. Excessive friction wastes energy and leads to wear of the surfaces. A lubricant acts to reduce friction and wear by creating a slippery film between the surfaces. When you look at some really smooth surface, if you look at it microscopically, it is rasp. It's not very smooth. So we need to have a certain fluid film between the surfaces to not have any wear. The thickness of that film is formed between the surfaces determines the effectiveness of the lubrication. What types of wear there are? Adhesive wear, abrasive, fatigue, and corrosive. Abrasive wear can be 2 bodies or 3 body wear. If we have a third body, then the wear is much more amplified. So imagine a situation you have a broken ceramic hip, a broken ceramic acetabular component. If there are small pieces of that ceramic and you revise it with metal on polyethylene, small pieces of ceramic can get stuck between the metallic head and the polyethylene liner, and that can cause a really terrible where in few months the acetabular component can be dissolved. Let's also put that a little bit into more clinical setting. We have a normal wear when two bare surfaces articulate with each other. We have when the bearing surfaces articulate the non-weight bearing surfaces, then third body wear that I just mentioned, and when non-bearing surfaces articulate also the non-bearing surfaces. That's most important in the backside wear. Backside wear is the wear of the polyethylene insert behind it together with the metallic component. That's very important in the people who routinely use screws for the acetabular component. If you use screws all the time, you amplify the joint space and you have more of the osteolysis. Types of lubrication, let's just say the hydrodynamic lubrication is the most effective one, where you have a fluid film in between. Lubrication in artificial joints. If we speak about the hip, we need to have polar contact with high conformity. So that's, sorry, I don't know what's going on. That's when fluid film can be formed. If we have an equatorial contact, not the polar contact, then we have the lockout. Sorry. Then we have the lockout of the liquid. So osteolysis, of course, is because of the polyethylene particles that are getting released in the free joint space with macrophages and osteoclasts actually resorbing the bone. What is tribocorrosion? Let's just say it's the material degradation or transformation of contacting materials resulting from the combined action of wear and corrosion together. I would quickly go through this and let's just put it in a clinical practice. The localization of the tribocorrosion, what's the most important way? And the most important parts of the joint are on bearing surfaces. If we have metal on metal bearing surface, then taper junction between the stem and the taper, and stem cement interface. Any modular connection involving metal alloys will show some corrosion if in contact with body fluids and exposed to micromotion. Different risk factors for the tribocorrosion of the hip, and I would really quickly go to the take-home messages. Metal debris does not happen only on metal bearing surfaces. Metal ions do cross placenta and can be released by tribocorrosion on the head and taper junction. That can have systemic effects. After ceramic breakage, put in ceramic on ceramic, never put PE liner in that cause. Fortunately, the third generation of ceramic, I have never seen it broken. Metallic head on ceramic acetabular insert is a Vici Martis. Recently, I just revised one. I don't know who put it. Surgical prevention, know your positioning angles and biomechanics. If you want to know more about biomechanics, this book, Orthopedic Biomechanics Made Easy, perfect book for starting of biomechanics. Can we do these questions? Please. This also on the stick. This first and then second. Since I want this to be a more interactive course, I will now give you 10 questions that were on the EBOT exam, basic science question, done by Professor Simon Donnell. Some of them are easier, some of them are hard. We can go through them and then go through the answers so you can see if you take the EBOT exam about how hard those questions are. Are you up for that? Okay, let's go. What is the predominant? So, what is the predominant collagen type for articular cartilage? You probably already saw the answer. So, collagen type 2. Collagen type 1 is in tendons and ligament. Type 2 is in articular cartilage. Others are, let's say, out of the musculoskeletal system. What would you say? Okay. Of course, water. Water is the highest component of the articular cartilage. 70% water, 15% minerals, and these are the others. Now, it's time for some harder questions. Tarek mentioned it in his presentation. Calcified cartilage is the driest level. This is the cartilage, the calcified cartilage. It's just the first one bordering the subchondral bone. Okay?
Sí, sí.
Hey, please feel free to comment. I mean, when I first saw this question, I didn't know it, honestly. So, hydrophobic effect of proteoglycans. Proteoglycans are actually hydrophilic. Breakdown of collagen cross-linkages happens in osteoarthritis. Movement of macromolecules, those are the shear forces. And, okay. So in aging,
Sí, sí.
that's great. So disruption of the collagen proteoglycan matrix. Okay. Interfacial wear, we already said it. There is adhesive, abrasive, fatigue wear, and third body wear. Also, the decreased joint lubrication doesn't happen with the old age. It happens in osteoarthritis, but it doesn't have to happen in the old age. Okay, a little bit more into clinics. Which is the ACR radiologic criterion for osteoarthritis? Just one. If you see it, you know there is OA present. The most sensitive sign. E, osteophytes. That's great, osteophytes. So, clinical signs are 1 month of articular knee pain for most days and 3 of the following. And radiological is radiographic evidence of osteophytes. Concerning the population of osteoarthritis, which of the following is true? We go a little bit into biostatistics now. What is more common, hip or knee OA? let's say knee. I would say knee OA is more common. So, and now we have to know what is incidence and what is prevalence. So, the incidence of knee OA is higher than hip. Osteoarthritis, okay, so prevalence is how many person with that disease there is in population. Incidence is the new incidence per year, okay. Which matrix metalloproteinase has the highest expression in osteoarthritis?
A.
D, very good. D, it degrades collagen 2 and aggregate. Yes? Okay, this is harder. Okay, sirtuins. I won't explain that. Just remember it, please. Okay. Actually, this is a bit of a misnomer because in hip it's tennis classification, not Kelvin Lawrence, but you you get the point. What would you say? I will go with 3. There is some osteophytes, there is a cyst, there is almost bone to bone, but not bone to bone. So 3 is multiple osteophytes, definitive joint space narrowing, sclerosis, and possible bone deformity. Okay, I have 10 more questions. Are you up for that, or should we keep the lectures? Let's do the questions. Let's do other 10. Some of them are easier, some of them are harder, but this is how EBOT looks like. It's very scientific and it's very theoretically based. I will just skip this one because it's very sorry. It's very unclear, the first one. So, which of the following is true for mitochondria? It's easy. We know it from the first year of medicine. They provide energy to cell. They're important in red blood cells. There is no mitochondria in red blood cell. They contain paternal DNA. No, they contain maternal. Contain a single membrane, no double, and diameter. I don't know who would know this, but okay. Okay. Let's go back to the first year of medicine. Yes, D. So, X-linked recessive. As you remember, this is man, this is female. You see, only men are affected, and females are just carriers. Okay. Okay, see? So this is this is an autosomal recessive. So some autosomal dominant disorders like Marfan, osteogenesis imperfecta, Neopatella, there are some autosomal recessive. As you remember, this is a sickle cell disease, was an autosomal recessive disorder. X-linked recessive, like hemophilia, we had it in the previous question. Multifactorial and chromosomal. If we have, let's say, dysplasia and mental retardation, it's usually a chromosomal one. Which one of the following is due to a mutation of the collagen gene?
You're going to do it? Yeah. Okay.
Try to remember in which disorder the collagen type 1 is affected. Nope. E. Very good. Osteogenesis imperfecta. It's the problem with collagen type 1. This question will just make you sad. I wouldn't know it in pro phase. So. Okay. Now we come to the oncology. Cartilaginous tumor, let's say chondrosarcoma. A, very hard question. So, cartilaginous tumors of bone, they usually do have point mutations in the genes. So, it's true of activated osteoclasts. Try to remember the picture of the image of the osteoclast. It has a ruffled border.
What about the Golgi complex?
Huh?
What about the Golgi? The
The-
Golgi, the Golgi.
The Golgi complex. No, they have a big Golgi complex actually. Extensive Golgi complex. They don't secrete alkaline phosphatase, they secrete acid phosphatase. These are tricky questions. Also, Tarek spoke about this. C. Okay. Easy question. It's produced in the kidneys. Okay. And I believe it's another easy question. We use it every day. CRP. It's made in liver. Okay, so it's pentameric protein. It's the protein of the acute phase. It activates the complement syndrome, and it's made in the liver. So, we're done with the questions. I'm going to skip my evidence synthesis presentation, and we can go to Tarek.
Tarek, yeah. Thanks, Marco.
Do you want to use the microphone or here?
Thank you.
Well, hi. Well, we're gonna start with investigation in orthopedic. Radiation safety should always be considered about the safety. The increase of the radiation exposure could be in imaging of large body parts, positioning closer to X-ray source, or use larger than smaller CR. Factor to decrease the amount of radiation are minimizing exposure time, using collimation, use of protective shield, maximizing distance between the surgeon and radiation, and utilizing the CR whenever feasible. Nuclear medicine, bone scan, technetium scan, use technetium-99 phosphate complex. It reflects the blood flow and metabolism, so is absorbed on the hydroxyapatite in the bones. We use it to detect the stress or subtle fractures, avascular necrosis, osteomyelitis, and also in total hip and knee arthroplasy, we detecting loosening, especially of femoral components. Gallium scan is localized in the inflammation and the neoplasia, less dependent of vascular flow, unlike the technetium-99. I don't know what's happened with this. Require the light imaging and is difficult in differentiating between the cellulitis and osteomyelitis. For example, here on the left picture, we have hyperactivity in the left hip on the technetium scan, but gallium scan doesn't show the ingress activity, so we can exclude osteomyelitis. Here on the right picture, we have a hyperactivity on the technetium and gallium scan, so we have high suspicion for osteomyelitis. Indium scan labeled to the white blood cells, collect in the area of inflammation, and do not collect in the area of neoplasia. So we can only detect the inflammations, but we have to be careful about the patient with sickle cell disease, because it labeled to the white blood cells, it could show the false positive results, like in this patient with total knee arthroplasty. Single photon emission computed tomography. We use it to detect femoral head osteonecrosis, patellofemoral syndrome, or spondylolysis. Arthrography, we commonly use it in combination with other study, for example, CT or MRI. Improves sensitivity of intra-articular soft tissue pathology, for example, labral tears in shoulder, TFCC, or intercarpal ligament tears. Most commonly used in hip, we use it to assess deformities in Leclerc-Perthes disease or following reduction in the development hip disorder. MRI is excellent for evaluating soft tissue and bone marrow. Lesions effective in evaluating trabecular bone because there is no hydrogen ion in the bone and cortical and trabecular bones. We use it to detect osteonecrosis, neoplasia, infection, and trauma. Contraindications, like we know, is the hardware, sharpener, cerebral aneurysm clips, or pacemakers. In the case of osteonecrosis, we detect ingrowth of vascular mesenchymal tissue, has 98% of specificity, and disease marrow is dark on the T1 weighted imaging. It is excellent for the occult fracture. Like I said, we have here the same patient with the plain radiological picture of the left ankle, but when we done MRI, we show the occult fracture of the talar dome. Neoplasia. Primary tumors are well demonstrated, particularly in soft tissue. After use in detection of the skip lesion, bending bones are typically bright on the T1 and dark on the T2 weighted imaging, unlike the malignant bone tumors, are often bright on the T2 weighted imaging. In the spine, disc disease are well demonstrated. What's happened? Degenerated disc lose water, so it appears dark on the T2 weighted imaging. Extent of herniation of the disc is also well shown. Most sensitive for early diagnosis of fasciitis, like we see here, T1 and the T2 weighted imaging, the sagittal view, we can see irregularity between L2 and the L3 fragment. Right here on the axial view, we can see here the atrophy of the iliopsoas muscle and the fluids in the paraspinal space, so it is indicative for the abscess. We use it also to make a differentiation between the scar. For example, on the T1, scar decrest signal, on the T2, it increst signal. Extruded disc decrest signal on the both, on the T1 and the T2 weighted imaging. Computed tomography demonstrates bone anatomy better than any other. Study in spine show herniated nucleus pulposus better than myelography. May be helpful in differentiating herniation from the scar. And intravenosus contrast is taken up in the scar tissue but not in the disc tissue. Images distorted by the metal implants. We have to be patient about that. Ultrasonography showed evaluation of the rotator cuff tears. In the hip, we diagnose and follow up development hip disorder. Dynamic examination of femoral acetabular impingement. Also in the knee, we can measure thickness of the cartilage and identification of the intra-articular fluids. In soft tissue, we have wider indications, for example, for hematome, tendon rupture, abscess, for agent bodies, and interspinal disorders in infants. Myelography is more invasive than MRI, but show excellent details, useful in patient with contraindication for MRI, for example, useful in the failed back pain, and can be used with CT in combination also. discography, help to evaluate symptomatic disc degenerations, pathologic disc reproduce pain with injection, and has characteristic changes on the discogram. Nerve conduction study used to evaluation of the peripheral nerves. Nerve impulses are recorded by the surface electrode, and the measure latency and response amplitude is what we measure. Late response allow evaluation of the proximal lesion. It's because impulse traveled to the spinal cord and then return back. Electromyography use intramuscular needle electrode to evaluate muscle units. We use it to evaluate fibrillations, sharp waves, and abnormal requirement pattern. Thank you.
We start the second prezi. So now at the end of this basic science session, I wanted to speak a little bit about orthobiologics. So how many of you are in your clinical practice are using PRP or stem cells? Okay. No, the second one. Yes. Okay, regenerative medicine. We speak when we actually help the body to help itself regenerate. I have to disclosure that I'm a paid consultant for Artrax and that I'm using Artrax orthobiologics in my clinical practice. So when we speak about the sports injuries, regular engagement in sports produces many health benefits, but it leads to increased injury risk. Acute injuries, they're called by, you can have different sports injuries, I won't get into that now. And you can have a chronic overuse injuries that we usually treat. They are caused by continuous stress during to repetitive movement or microtrauma. So we have stress fractures, tendinitis, bursitis, and chronic compartment syndrome. The pathophysiology is about more damage than the body can endure and that the body can heal during the time. Sorry, the pointer is working by itself. As a result of major injuries through their career, elite athletes commonly develop osteoarthritis and most commonly on the knees. This doesn't work. I mean, it's shifting by itself. Okay. So this is how many in the 90s were the knee arthroplasties and how many in 2010. So younger and younger people are getting knee arthroplasties. So we try to further that down to the older age as much as possible. So athletes seek novel regenerative medicine interventions to heal injuries and rapidly resume their desired level of sports activities. When we speak about the healing process, we speak about ligament, tendon, muscle, and cartilage. So we have the inflammation phase, proliferation phase, and remodeling phase, of course. The usual interventions that were done 20 years ago consider NSAIDs that could have deleterious effects of ligament healing and usage of corticosteroids that are proven to have negative effects on quality of healed tissue. So when we speak about cartilage regeneration, it's the second most differentiated tissue just after nerve tissue. Naturally, it doesn't regenerate with new cartilage, it regenerates with fibrous tissue, and so it doesn't go to restitutio ad integrum. We were doing in the past microfractures, we still do them sometimes, autologous chondrocyte implantation, mosaicplasty, osteochondral allograft, and we have other non-operative cartilage beneficial treatments, like chondroitin sulfate taken orally, hyaluronic acid, usually in injections, platelet-rich plasma, and stem cell therapy. Most promising techniques used are platelet-rich plasma and adipose-derived stem cells, or SVF. Of course, we have bone marrow-derived stem cells and blood-derived protein mixtures like orthokin, if you had a chance to contact it, to get into contact with that. Regenerative medicine, in general, uses potential cell biology for tissue replacement, which will restore lost functionality. Please look at this graph. Whatever we inject in the knee, out of treatment options, we do have some kind of improvement. In the period of 1 month, for knee osteoarthritis, corticosteroids have the biggest impact. The biggest benefit is from corticosteroids. But in period of 3 months, it goes even under the saline, the physiological solution. So if we give physiological solution, for 50% of patients, it's going to be better in 1 month. But after that, it deteriorates. The orange is for hyaluronic acid, where the good benefits last for about 6 months. Then we have PRP, and then we have stem cells. So let's say the stem cells are leading. It's not a magic wand. It doesn't delete all the symptoms, but it has the biggest effect on the benefits after 1 year. So, what is PRP? It's a fraction of autologous blood, plasma with platelets concentration above the baseline. So after the centrifugation process, we need to have the higher level of thrombocytes, of the platelets inside the plasma. It has the anabolic effects on ligaments and tendons and on cartilage. That has been proven too. It was developed in the 70s, first used in 1987 on the open heart surgery. It gained popularity just like everything else in medicine. In Europe, towards Rafa Nadal, who had numerous PRP injections in his knees, and in USA, Tiger Woods. These were all the procedures that he has done through the years. He had more than 11 surgeries. Basic science behind the PRP. Platelets form fibrin clot. The growth factors and cytokines are released from that fibrin clot, like FGF, TGF, PDGF, and so on. Fibroblasts proliferate during the proliferative phase, and these growth factors regenerate the extracellular matrix. These are activated platelets. These are non-activated platelets on electronic microscope. And in the healing, in the healing cascade, during the inflammation phase, if we give PRP, we actually lower down the inflammation, and if we give it during the proliferation phase, we actually elevate inflammation a little bit. For certain condition, we need to lower down the inflammation process, like if we give it intra-articularly for osteoarthritis. If we want something to heal faster, like a torn muscle, we need to give more platelets to elevate inflammation a little bit and to speed up the healing process done by the localized inflammation. So, blood components of the just clear blood is plasma plus 93% of red blood cells, 6% of platelets, and 1% of white blood cells. After the centrifugation, after the spinning is done, it has 92% of the platelets in plasma, 5% of the red blood cells, and 3% of the white blood cells. Comparison between actually different products of the shelf, so region, Arthrex ACP, and so on. This is the number of platelet and growth factors. We won't get into numbers now. So we need to have as many platelets as we can without taking so many leukocytes. So we don't want neutrophils there, because leukocytes, in particular in neutrophils, they cause inflammation, pain, and tissue degradation. Therapeutic dose. We can differentiate between platelet poor and platelet rich plasma. PRP is platelet rich plasma, but there is always a possibility to give platelet poor plasma for conditions such as osteoarthritis. There is still no consensus about using only rich, only poor, or both should be used together. Most believe that platelet numbers should be increased 2.5 to 3 times compared to the blood, and 3 to 7 milliliters are usually administered in off-the-shelf products. When we do the spin, the red blood cells go down, the white blood cells and platelets are in the middle, and the platelet poor plasma is there. So this is the PPP, platelet poor plasma, platelet-rich plasma, and the red blood cells. Many commercial kits have different end products. So we have plasma-based and Buffy coats. It depends how many spins we did. So Buffy coat has higher platelet concentration, and it's a more gel-like structure. It's not liquid. It has also the higher concentration of white blood cells and red blood cells. So this Buffy coat is after 2 spins, and it's a gel-like structure. It's good to use it surgically, intraoperative, but it would be hard to inject it. These are Buffy coat systems and plasma-based systems on the market. Anito and Sanchez were the first ones in Europe, in Spain, who actually used PRP. So this is that gel that we can extract, and this is the PRP, the plasma. The results. Various studies show different results depending on the PRP type, tissue being treated, body part, and patient-specific results. So, platelet-poor plasma has been proven more beneficial for intra-articular use for less inflammatory effect, less leukocytes. Plasma-based systems have less white blood cells and red blood cells contamination and better platelet function. PRP in different tissues, filling the bone tunnels in ACL reconstruction has no benefits, and the studies have shown that. For lateral epicondylopathy, tennis elbow, PRP was proven superior to corticosteroids or dry needling. For Achilles tendinopathy, PRP was proven superior to placebo. For knee osteoarthritis, PRP was proven superior to hyaluronic acid and corticosteroids. More efficient is in early osteoarthritis. And inconclusive result for meniscal tears and rotator cuff tears. For rotator cuff tears, I'm very pessimistic. BMI and age, of course, better results in younger patients and in patients with lower BMI. For early osteoarthritis, 3 injections achieved better clinical results than 1 or 2 injections. For late OA, there was no difference. Growing evidence of synergistic effect with hyaluronic acid. Should it always be administered together? I personally, intra-articularly, do it together with hyaluronic acid. For anywhere outside the joints, I don't use hyaluronic acid. Conclusion. It's easy to extract. You take blood from cubital vein. Extremely low chance of infection. Never had an infection with using PRP, and can be used for tendinopathies, early osteoarthritis, and acute soft tissue injuries. Stem cells. Those are cells that have a capacity to remain in undifferentiated state until stimulated. The ability to differentiate into multiple tissue lineages, and the ability to undergo more replicative cycles. There are many misnamers here. If we speak about the pluripotent cells, pluripotent cells means the cells that the embryo can develop from. These are not the pluripotent cells. These are the multipotent cells. So the mesenchymal multipotent cells that can develop every cell from a mesenchymal lineage. So that means it can turn to bone cell, cartilage cell, muscle cell, stromal cell, tendon, or adipose cell. So it cannot become a neural cell or a hematopoietic cell. Basic science behind it. Parasites surround blood vessels in all of our body. Parasites around blood vessels are multipotent mesenchymal stem cells. This is the electronic microscope image of it. They have a potential to differentiate into bone, cartilage, tendon or ligament, and adipose tissue. They also have a secretory anti-inflammatory function, and they can provide angiogenesis. When we say MSCs, MSCs means mesenchymal stem cells. Now they're pushing, actually I'm part of the ESCA consensus group concerning PRP and stem cells, and now we are pushing other name that MSCs should mean medicinal signaling cells, because I believe personally that more effect it has from releasing anti-inflammatory products than from being a stem cells that can turn into cartilage, because that's a long way process and very doubtful that it can. But its signaling effect is actually what brings the benefits. SVF composition. SVF means stromal vascular fraction. I will explain what that is. So it's hematopoietic stem cells, endothelial cells, smooth muscle cells, and adipose-derived stromal stem cells. We make a small liposuction, take fat tissue from the belly, and we mix it together, break the fat tissue, and then actually inject all of that into a knee after removal, oil, water, and blood. So 2 to 10% of this fraction is actually adipose-derived stromal stem cells. Others are not. It would be hard actually to make the sample more clear. Now we'll speak about that. Should we do the cell culture? If we do the cell culture, if we just grew in the laboratory conditions, just adipose-derived stem cells, we would have a pure sample, a larger sample, and we would increase the number of application. Of course, contraindications are it's profoundly complicated. You have to do it with growth factor, you have to have a lab technician, and it sometimes doesn't work. We have many regulations. I don't know how it is in Romania, but in most European countries, and I believe in Romania too, that you can take a tissue and inject it in the same procedure. But you cannot take a tissue without many regulations, grow it and inject it later. I believe it's the same in the whole European Union. And it's of course time and money consuming. Large RCTs have shown that there are better results when injecting SVF, so the freshly prepared just mesh tissue, than the pure culture, because it has more of that signaling effect. Okay, we already spoke about this. So once again, stromal vascular fracture is that adipose tissue can be considered the richest sources of stem cells in our body. Of course, these parasites cover all the blood vessels in our body, but we won't take part of our heart or brain to extract stem cells. Everybody likes to get rid of the fat tissue. Procedure starts with liposuction and local anesthesia. From 30 milliliters of fat tissue, 1.5 to 2 milliliters of SVF is obtained and can be applied by needle injection or intraoperatively. This is how the fragmentation is done. And here we have fat, we have the SVF, and we have the blood. So stem cells, they actually produce cell. We need to have the conduction, some scaffold that we're going to give it with, and we need to have growth factors that are going to induce these stem cells to maybe become new cartilage. PRP has the ability to alter the hostile environment and give growth factors. We cannot forget that joint with late OA looks like this. If we're going to inject it in late OA, we expect lower pH, low nutrients, a lot of matrix metalloproteinases, and pro-inflammatory cytokines. That's why I always, when I give stem cells, I combine it with PRP and hyaluronic acid. Hyaluronic acid actually reduces the acidity. It buffers the solution. So PRP has also an anti-inflammatory effect, acts as a fibrin scaffold, actually integrates these stem cells in it. It has growth factors and it has cytokines. Results of the stem cells, depending on the tissue being treated. Age and BMI of the patients, of course, play a role. It's beneficial in early OA and in Achilles tendon tendinopathy. It's beneficial for intra-articular delivery for the ACL graft for the graft maturation. It's inconclusive for meniscal tear and for cartilage defects. When I decided to use it, I found this paper that in 10 years they had no tumors. I mean, when you inject in stem cells, my biggest fear was if I inject stem cells, is there a chance for a patient that those cells go malignant? They don't. So it's safe to use it concerning the possible malignancy. But we need to be careful with conclusions. Most of the studies combine stem cells with PRP and hyaluronic acid. We don't know how much of a benefit was from each of these factors. Stem cells implanted by arthroscopical procedure on some kind of scaffold show better results than the injected stem cells. Of course, it's more precise. When we actually make a comparison between adipose-derived stem cells and bone marrow, SVF has proven more effective with better growth properties. SVF stem cells are more genetically stable. In conclusion, there is a growing number of published clinical trials, but still lacking RCTs. It's a new technique with promising results with many factors included. Once again, whatever you inject into the knee, you will get some benefit. But it looks like that stem cells and PRP are the leading in the field. Okay, and greetings from FORTE to conclude this session. Thank you so much. I would open a quick debate. If you want to ask anything about the orthobiologics, anything about the previous lessons, all of the faculty are at your disposal.
Dacă aveți întrebări, ridicați mâna și vă aduc microfonul. Bine?
Okay, so maybe we can just rest for 5 minutes and then...
No, let's do it for 15 minutes.
Okay.
So we're going to do a 15 minutes break, and we'll come back with the spine session, and yeah, we'll talk to you later. And we want, first of all, I'm sorry, I have to say some words about Professor Stoica that invited us here.
I wanted that when Professor Mineiro arrives.
We can do it close up then.
Yeah,
nice.
I planned that.
Yeah.